I'm Dr. Fakiraveri and this is Bacteremia in adults. Here are some reliable resources for this topic. Infectious Diseases Society of America, or RDSA, provides guidelines, and we will focus on IDSA guidelines for bacteremia. First, in 2009, IDSA released guidelines for the diagnosis and management of intravascular catheter-related infections. Then in 2011, IDSA had specific guidelines for MRSA, or methicillin-resistant Staphylococcus aureus infections. This is a wide variety of infections due to MRSA, including bacteremia. So there is a section in there that's specific to bacteremia due to MRSA. There is also a consensus guidance that was published in 2020-21 for optimizing the management of uncomplicated gram-negative bloodstream infections. And more recently, IDSA has a guidance on the treatment of antimicrobial resistant gram-negative infections. The next learning objective is describe the common mechanisms of bacterial resistance to antibiotics. Wild-type bacteria are susceptible to many antibiotics, and they are called wild-type because they have not developed resistance through mutations or acquisition. However, they can still be resistant to some antibiotics intrinsically, and that's what determines the spectrum of activity of antibiotics. Resistant bacteria are the ones that are resistant to antibiotics that normally should have been susceptible to as wild-type. For example, wild-type Staphylococcus aureus is susceptible to penicillin, but you will see that many Staphylococcus aureus strains have developed resistance to penicillin. Wild-type Pseudomonas aeruginosa is intrinsically resistant to penicillin. Now, when bacteria develop resistance, not only can they pass these resistance genes when they divide, but they can also pass it to other species. The transfer of resistant genes occurs generally through 4 different mechanisms. Transformation is when naked DNA transfers from dying bacteria to a competent recipient. Transduction is the packaging of genes, usually from small plasmids, by transducing bacteriophages. One characteristic of bacteria is that in addition to their chromosome, they also have DNA as a circular DNA, which is referred to as plasmid. And this plasmid, because it's small in general compared to chromosome, it can easily be transferred to other bacteria. In conjugation, which is the most efficient way of transferring resistant genes to other species, self-transferable plasmids mediate direct contact by forming a mating bridge between cells. You can see in the picture in the right hand side the different steps of conjugation. Lastly, there can be conjugative transposition. You see, as opposed to chromosomes and plasmids, transposons are specialized sequences of DNA that possess their own recombination enzymes, allowing transposition or hopping from one location to another, independent of the recombinant enzymes of the host. Here are the common mechanisms of antibiotic resistance. Remember, for antibiotics to work, they need to get to the site of action. This provides several opportunities for the bacteria to prevent antibiotics from getting to the site of action. The first mechanism is reduced permeability. In this picture, we're looking at gram-negative bacteria with 2 membranes, so there's the inner and outer membrane. And for many antibiotics to get to the site of action, they need to penetrate through the outer membrane, often by going through a porine channel. So one thing that bacteria can do is to reduce the production of these porine channels, or in some cases even loss of porine production. And that will basically eliminate the channel of entry for antibiotics. There is also something referred to as biofilm, which we will discuss when we talk about bone and joint infections. Now, if the antibiotics manage to go through the outer membrane, some organisms can actually develop efflux pump and pump these antibiotics out. This is a common mechanism in Pseudomonas aeruginosa. Another mechanism is the change in antibiotic targets by mutation. So if the antibiotics do get to the site of action, then the site of action can mutate so that the antibiotic can no longer bind to the site of action. The fourth mechanism is modification of antibiotics itself. So there are beta-lactamases that can actually break down antibiotics. There are also aminoglycoside modifying enzymes that can basically alter aminoglycosides. And lastly, there is alteration of metabolic pathways. For example, the evasion of common pathway to make folic acid, which leads to resistance to trimethoprim sulfamethoxazole. Now, there are other mechanisms of resistance, but these are the common ones that we will focus on. Now, let's compare gram-positive and gram-negative bacteria. So on the left, we can see gram-positive, which only has the inner plasma membrane. There is no outer membrane. So on top of the membrane is the peptidoglycan layer. With gram-negative, there are two layers. So there's the inner and outer membrane, and between the two membranes, there is a small layer of peptidoglycan. Beta-lactams prevent the formation of peptidoglycan. So their site of action is where peptidoglycan is. So in order for the bacteria to make beta-lactamase and break down beta-lactams, they need to be made around the peptidoglycan layer. So you can see that for gram-positives, so this will be actually outside of the cell, whereas for gram-negatives, these beta-lactamases will be basically in the periplasmic space between the two membranes. This basically shows you that with gram-positives, they are likely to lose a lot of these beta-lactamases to the environment because there is nothing to hold all these beta-lactamases as they're being made by the bacteria. Whereas for gram-negative organisms, because of the outer membrane, they can hold on to beta-lactamases. So this is more cost efficient for gram-negative. So you will see that beta-lactamase production is a lot more common in gram-negatives compared to gram-positives. ESBLs are an important mechanism of resistance in gram-negative organisms. But before we can talk about ESBLs, let's consider what is a beta-lactamase. So beta-lactam ring is essentially a 4-member ring, and monobactams only have this 4-member ring, and penicillin, cephalosporins, and carbapenems have 2 rings fused together. And what some bacteria can do is that they can make a protein called beta-lactamase, which can essentially break down the beta-lactam ring, and by opening it, they will make the beta-lactam inactive, and that is a mechanism of resistance for them. And there are a lot of beta-lactamases out there. So there are penicillinases that can break down penicillins in general. And then, later on, when we brought cephalosporins to the market, bacteria learned how to make cephalosporinases, which can break down cephalosporins. And later, when we had carbapenems on the market, they learned how to make carbapenemases. And collectively, these are all referred to as beta-lactamases. And of course, to fight that, we also made beta-lactamase inhibitors. And what beta-lactamase inhibitors are essentially compounds that look like a beta-lactam ring, so that they have affinity for these enzymes that bacteria make. And by binding to the beta-lactamase inhibitors essentially make this inactive, so that these beta-lactamases can no longer inactivate the actual beta-lactam, so the beta-lactam can remain active and kill the bacteria. And we have quite a few of them on the market now. We have clavulanic acid, tazobactam, sulbactam, avibactam, weberbactam, and more recently, relibactam. Now, what exactly are ESBLs, or extended spectrum beta-lactamases? So these are the enzymes that can hydrolyze extended spectrum cephalosporins and monobactams. And extended spectrum cephalosporins are essentially 3rd generation cephalosporins, such as ceftriaxone. And they do not hydrolyze cefamycin, so cefamycin are a subset of 2nd generation cephalosporins, and they can also not hydrolyze carbapenems. Now, ESBLs are susceptible to most beta-lactams with the exception of sulbactam. So sulbactam does not have good activity or affinity against ESBL. There are different ways to classify beta-lactamases. The easiest one is the Ambler classification that basically classifies them as class A, B, C, and D. Now, from a biochemical perspective, Ambler class B is metallo-beta-lactamase, whereas class A, C, and D have a serine moiety. Class A can be a bit confusing because it has several subclasses. So first we have penicillinases and cephalosporinases, such as TEM1 and SHEV1. And these basically break down penicillins as well as first and second generation cephalosporins. These are sometimes referred to as narrow spectrum beta-lactamases. Then we have extended spectrum beta-lactamases or ESBLs. And these basically are for the most part CTX-M as well as derivatives of TEM and SHEV. And the reason these are called extended spectrum is that in addition to penicillinases and cephalosporinases that break down penicillins and first and second generation cephalosporins, they also break down third generation cephalosporins, as well as aztreonam. Then we have carbapenemases, which basically for the most part is KPC. And what that means is that in addition to penicillinases and cephalosporinases, these also break down carbapenems. Class B, which is metallo-beta-lactamases, are the worst in class, so they basically break down everything except aztreonam. Then we have class C, which is for the most part the AMP-C enzyme, and these break down cephalosporins and penicillins as well as imipenem, but they are stable to many fourth generation cephalosporins as well as meropenem. And lastly, we have class D, which are OXA type enzymes, and these are carbapenemases. So in addition to penicillins and cephalosporins, they also break down carbapenems. Now, over the years, we have developed many beta-lactamase inhibitors that can be bundled with beta-lactamases in order to prevent beta-lactamases from breaking down the beta-lactams. So we have clavulanic acid, which can inhibit class A, including ESBL, but not carbapenemases. It can also inhibit class C, but not class B or D. Sulbactam has activity against class A, but not ESBLs or carbapenemases. It is active against class C, but not class B or D. Tazobactam is active against class A as well as ESBL, but not carbapenemases, and not class B or D. It is active against class C. Avibactam, which is a broad spectrum beta-lactamase inhibitor, is active against all class A, including ESBL and carbapenemases. It is active against class C as well as class D, which is OXA48 type. But it is not active against class B. Weberbactam is active against all of class A and C, but not class B or D. And Relibactam is active against all class A and C, but not class B or D. Now, in addition to their inhibition of beta-lactamases, some of them also have activity on their own against some organisms. Now, the one that's clinically important is that sulbactam itself is active against Acinetobacter. So this is something that clinically is used. So regardless of what sulbactam is bundled with, in the United States it's bundled with ampicillin. So we have ampicillin sulbactam. So the sulbactam component, but not ampicillin, has direct activity against Acinetobacter and is sometimes used clinically. That was a lot of information, so let's summarize. In general, beta-lactamases can be broken into serine beta-lactamases and metallo-beta-lactamases, and the Ambler classification can be used to classify these beta-lactamases. So class A can be divided into narrow spectrum, ESBL, and carbapenemases. Narrow spectrum includes TEM1 and SHEV1, among others. And fortunately, we have many beta-lactamase inhibitors on the market that can inhibit these beta-lactamases. Now, in addition, there are also ESBLs under class A, and these are CTX-M for the most part, but there are also some derivatives of TEM1 and SHEV1 which have over time mutated, so we call these TEM type and SHEV type. There are many different ones of these, and these are extended spectrum because they can break down third generation cephalosporins as well as monobactams. Now these are pretty much inhibited by most of the beta-lactamase inhibitors on the market except sulbactam. Now the worst type of amyloid class A are the carbapenemases, including KPC, one of the most common ones, and there are a select few beta-lactamase inhibitors that can block KPC. Now, just because these are called carbapenemases doesn't mean that they cannot break down penicillins or cephalosporins. They do. Now, amyloid class C, for the most part, it's cephalosporinases, AMP-C, and they do break down one carbapenem, imipenem, but they cannot break down meropenem or doripenem. And fortunately, many of these beta-lactamase inhibitors can actually inhibit AMP-C. And the worst type of class serine beta-lactamases are class D. These are carbapenemases as well. And the most common one, or perhaps most clinically relevant one, would be OXA48. And the reason this one is important is that this is the only one that's inhibited by avibactam. Anything else in class D is not inhibited by the beta-lactamase inhibitors on the market. And then overall, the worst type of beta-lactamases are the metallo-beta-lactamases. These are under amyloid class B, and these are also carbapenemases. So IMP, NDM, and WIM are common examples. And unfortunately, we don't have any beta-lactamase inhibitors on the market that can inhibit this. Let's take a look at Staphylococcus aureus. So Staphylococcus aureus can be divided based on its pattern of resistance. So the wild type, which is basically penicillin susceptible, is constituting less than 10% of the isolates nowadays. Then we have MSSA, which is methicillin susceptible. MSSA is resistant to penicillin. Then we have methicillin resistant, so MRSA, and the drug of choice for MRSA is vancomycin. Now, while very rare in the United States, there is also vancomycin intermediate Staphylococcus aureus, or VISA, and that is basically that Staph aureus is no longer susceptible to vancomycin, but the MICs happen to be in the intermediate range. And then we have Staphylococcus aureus with MICs in the resistant range for vancomycin, which is referred to as VRSA. Now, MRSA is clinically important, and in general, there are different types of it. So we have healthcare-associated MRSA, and then we have community-associated MRSA. Now, there's also livestock-associated MRSA based on the antibiotics that are used in animals and in food production. But clinically, we basically break these down into healthcare-associated MRSA or community-associated MRSA. And healthcare-associated is the more common strain, which most healthcare professionals encounter. And this strain is resistant to beta-lactams, with the exception of ceftaroline, and several other classes, making prefer therapy more broad-spectrum agents. Now, community-acquired MRSA is strain only found in the community, and other classes other than beta-lactams are still possibly active against these, so such as like doxycycline, moxifloxacin, trimethoprim sulfamethoxazole. Now, something of note is that the resistance genes that make Staphylococcus aureus resistant to methicillin is the MEK-A gene, which can be identified on rapid diagnostics, and this is the gene responsible for alterations in penicillin binding protein 2A, and that is the target site for methicillin class, so nafcillin and oxacillin, as well as cefazolin, they bind to the site. So when there is mutation, alteration in this, they no longer can bind to penicillin binding 2A, which makes it resistant to that class. Enterococcus species, which are gram-positive, can develop resistance to aminoglycoside in 25 to 50% of the isolates. And these are basically plasmid-mediated resistance that are aminoglycoside modifying enzymes. And of course, there is vancomycin-resistant enterococcus, or VRE, and there are two main genes that make VRE. So VAN-A and VAN-B, both of which can be identified with rapid diagnostic tests. And basically, the site of action for vancomycin is the alanine. And what happens in enterococcus with these genes is that basically it mutates and changes the second alanine to a lactate. And as a result, vancomycin can no longer bind to the alanyl D-lactate. And this mutation basically does not interrupt the life cycle of enterococcus. So enterococcus at this point will be VRE. It continues to replicate, and vancomycin will be ineffective. Now, enterococcus is part of the human flora, so it is common for people to be colonized with VRE, and that's something that can be detected by screening tools on the stool sample. Lastly, let's take a look at E. coli. So E. coli is a gram-negative rod, and it can be resistant to many antibiotics, so including resistant to beta-lactams, and it's primarily through various beta-lactamase production. So including some strains can be ESBL producing, as well as KPC, which is a carbapenemase, as well as OXA48, which is a carbapenemase, and of course the whole subclass of metallo-beta-lactamases that are carbapenemases. So E. coli can be very resistant. At the same time, a wild-type E. coli can be pan-sensitive to many antibiotics. Now, trimethoprim sulfamethoxazole resistance is basically increasing, and it is due to overproduction of dihydrofolate reductase. So dihydrofolate reductase is the site of action for trimethoprim, as well as mutations in the gene DHPS is the site of action for sulfonamide, so sulfamethoxazole. Fluoroquinolone resistance can be due to polymorphisms in the GIR-A, which is a gyrase, the gene for the gyrase. And basically that's the site of action for fluoroquinolones such as ciprofloxacin. Tetracycline resistance can be due to expression of efflux pumps, which is encoded by the... We described the common mechanisms of bacterial resistance to antibiotics. Now let's explain the mechanism of action and spectrum of activity of beta-lactam antibiotics. There are four classes of beta-lactams. There are penicillins, cephalosporins, carbapenems, and monobactams. And they are all bactericidal. What bactericidal means is that they actually kill the bacteria very fast. So as time goes forward, the number of colonies actually drop very quickly. As opposed to bacteriostatic agents that don't necessarily drop the number of colonies, but actually halt the growth of bacteria. So the number of colonies actually stay the same over time. Beta-lactams bind to penicillin binding proteins, or PBP. And there are different types of penicillin binding proteins which result in different spectrum of activity of beta-lactam antibiotics. Now, the first beta-lactams are penicillins, so these enzymes were named after the first beta-lactams, so they are called penicillin binding protein, but they are also known as transpeptidase. And transpeptidase is an important part of cell wall synthesis. So by inhibiting penicillin binding protein or transpeptidase, beta-lactams inhibit cell wall synthesis. Now, without going into too much detail, the synthesis of peptidoglycan involves several steps, and one crucial step is the cross-linking of components of peptidoglycan, and that cross-linking is done by transpeptidase enzymes, and that is the site of action of beta-lactams. Let's take a look at the spectrum of activity of penicillins and monobactams first. So when it comes to penicillins, these are there are essentially subclasses of penicillins. So the first penicillins to come to the markets were actually called penicillin, and we have two different forms, penicillin G and penicillin V, with identical activity. And these have good activity against beta hemolytic strep, but they may not have the best activity against Streptococcus pneumoniae. Now, they are active against most E. faecalis, but they have no activity against Enterococcus faecium, and they are not active against any Staphylococcus aureus. So MSSA and MRSA are not active. There is a small subset of Staphylococcus aureus called penicillin susceptible Staph aureus that these agents are active against, but those are essentially less than 10% of all Staphylococcus aureus. And the reason is that majority of Staphylococcus aureus actually produce penicillinases that break down penicillin, so they don't have activity against MSSA or MRSA. And they don't have any activity against gram-negatives as well as anaerobes or atypical organisms. Now, the next set of penicillins are referred to as anti-staphylococcal penicillins. So these are nafcillin, oxacillin, dicloxacillin. So these are colored the same just to help you navigate this chart. So the three have identical spectrum of activity. Now, they are called anti-staphylococcal penicillins because they have activity against MSSA. However, they are not active against MRSA. In fact, none of the penicillins are active against MRSA. Now, when these became stable against MSSA, it came at the cost of losing some of the activity, including they lost activity against E. faecalis, and they had generally poor activity against beta hemolytic strep and strep pneumo. Now, the next set is aminopenicillin. So this is ampicillin and amoxicillin, which have identical spectrum of coverage. Ampicillin and amoxicillin, they do have improved gram-negative activity compared to the previous subclasses of penicillin. So they get some activity against H. flu and including E. coli, Klebsiella, and protease. But it comes at a cost because they lost activity against MSSA because they are no longer active or stable against penicillinases that Staph aureus makes. Now, they do have activity against beta hemolytic strep and E. faecalis and somewhat against strep pneumo. Now, by adding beta-lactamase inhibitors to these two, so now if you combine ampicillin to sulbactam and amoxicillin with clavulanate, you gain some of these activity. So now the penicillinases from Staphylococcus aureus are neutralized by these beta-lactamase inhibitors. So ampicillin, sulbactam, and amoxicillin clavulanate are active against MSSA, and they do gain better activity for gram-negative organisms. And more importantly, they also gain activity against Bacteroides, which are anaerobic organisms. Okay, so Bacteroides also make penicillinases that pretty much kill majority of penicillins, but the ones that have beta-lactamase inhibitor, including piperacillin tazobactam, they gain activity against Bacteroides. Now, Bacteroides become very important when we talk about intra-abdominal infections. Now, the last and the broadest penicillin is piperacillin tazobactam, so excellent activity against beta hemolytic strep, against strep pneumo, as well as E. faecalis, but not against E. faecium. It does have activity against MSSA, but not MRSA, and pretty good gram-negative coverage overall. But more importantly, this is the only the only penicillin that has activity against Pseudomonas aeruginosa. Now, the only monobactam on the market is Aztreonam, and it's important to note that Aztreonam does not have activity against any gram-positive organism, so it's all red for gram-positives. Now, it does have some good activity for some of the gram-negatives, including H. flu, as well as some of the Enterobacterialis. However, it does have somewhat poor activity against Pseudomonas. So over time, activity of Aztreonam over Pseudomonas has decreased. And moreover, it doesn't have activity against Bacteroides or atypicals. Now, let's take a look at cephalosporins. We have a lot of cephalosporins on the market. These are select few that are more commonly encountered, but there are a lot more. And cephalosporins in general are thought of in generations. So there is first generation, second generation, third generation, and fourth generation. And then at some point, we kind of stopped calling generations because it started to be inconsistent. Now, in general, you go from narrow spectrum to broad spectrum as you go higher with the generations. So we have for the first generation, cefazolin and cephalexin. They have essentially identical spectrum of coverage, so good activity against beta hemolytic, somewhat activity against strep pneumo, and nothing against enterococcus species. And they do have activity against MSSA, so even though Staphylococcus aureus makes penicillinases, it cannot break down cephalosporin, so this is active, but they do not have activity against MRSA. In fact, ceftaroline is the only beta-lactam in general that has activity against MRSA in the US among the agents that are available in the US. There are other beta-lactams that are available elsewhere that may have activity against MRSA. Now for gram-negative, first generation, they have somewhat activity against E. coli, Klebsiella, and protease, but you typically need susceptibility results to confirm, and they don't have activity against Pseudomonas, Bacteroides, or atypicals. Now when we go to second generation, again, it's important to note that there is a subset of second generation referred to as cefamycin, so that's cefoxitin and cefotetan. And the rest of second generations, one example is cefuroxime. Cefuroxime has good activity against beta hemolytic, but not strep pneumo. And again, all of them are good with MSSA. When it comes to gram-negative, cefamycins have improved activity against gram-negatives, especially some of the Enterobacterialis. And cefamycins also have activity against Bacteroides, so that's unique. When you look at cephalosporins, none of them have activity against Bacteroides except for the two cefamycins that we have. Now, third generation cephalosporins, you will see we have the first three are oral, and then we have the IV formulations. So in general, somewhat good activity against gram-positive organisms. And then when you go to gram-negatives, in general, they have pretty good activity against gram-negative organisms, but they are not active against Pseudomonas except ceftazidime. So ceftazidime is the only member of the third generation cephalosporins which has activity against Pseudomonas aeruginosa, and it has a very good activity, ceftazidime. When it comes to fourth generation, cefepime is the only fourth generation we have, and the unique thing about it is again Pseudomonas, excellent Pseudomonas activity, and it also has good gram-positive activity, so beta hemolytic, strep pneumo, and MSSA. And ceftaroline, which some people would call it fifth generation, and others would call it anti-MRSA cephalosporin, because it's the only cephalosporin in the US with MRSA activity, and it's also has activity against Ephicalis, and good activity against gram negatives, but the only hole in it when it comes to gram negatives is that it does not cover Pseudomonas, so that's one shortcoming of ceftaroline. And more recently, we had cefiderocol come to the market, and just like aztreonam, cefiderocol does not have activity against any gram-positive, but it has perhaps the best activity against gram-negative. So it pretty much covers anything that's gram-negative that's clinically important, including Pseudomonas and Acinetobacter. Pretty much majority of these beta-lactams are not good against Acinetobacter. Cefiderocol has good activity. So cefiderocol is a novel siderophore cephalosporin. It is still considered a beta-lactam, but so it does bind to penicillin binding protein, but it's somewhat unique because the way that it enters the cell is that it hijacks the siderophore that comes with the bacteria. So what the siderophores do, they're actually natural iron chelating molecules that are released by bacteria to facilitate the transport of iron into cell for survival. So bacteria do need iron to go into their cell. And what cefiderocol does is that it hijacks, so it's kind of like a Trojan horse, and it hijacks the system to find entry into get entry across the outer membrane, so that it can bind to penicillin binding protein. And this is kind of neat because it can overcome some of the mechanisms of resistance in gram-negative. So because it doesn't depend on porin channels to enter outer membrane, it doesn't matter if the bacteria make changes in porin channels. And it's also somewhat stable to efflux pumps. So, that's the reason for its excellent activity against many gram-negative organisms. And to make it even better, its structure is stable against hydrolysis by many beta-lactamases, including metallo-beta-lactamases. So remember, when it comes to metallo-beta-lactamases, these are amyloid class B. They pretty much break down all of the beta-lactams, and none of our beta-lactamase inhibitors can block these. Now, cefiderocol is actually stable against metallo-beta-lactamases, meaning metallo-beta-lactamases cannot break down cefiderocol. So here's a figure that it shows you how cefiderocol goes across the outer membrane into the periplasm space where it can bind to penicillin binding protein. So essentially it hijacks the system where the bacteria is trying to bring iron in, and cefiderocol hijacks the system and goes in and finds penicillin binding protein. Now let's take a look at the spectrum of activity of carbapenems and cephalosporins. So essentially we have ertapenem, which has a narrower spectrum of activity compared to other carbapenems, and the reason is ertapenem does not have activity against Pseudomonas, so it's somewhat narrower compared to the rest of them. Now all of them are active against Bacteroides, and all of them are active against MSSA, but none of them are active against MRSA. Imipenem has really good activity against pretty much most of the clinically important organisms, including Pseudomonas. It's also active against E. faecalis. With meropenem and doripenem, pretty much identical to imipenem, with the exception of E. faecalis. They are not active against E. faecalis. Now, more recently, we have added beta-lactamase inhibitors to meropenem and imipenem to overcome some of the carbapenemases that are made by Enterobacterialis. So you will see that the spectrum of activity in this table looks the same, but essentially the advantage of these two is that things like E. coli and Klebsiella, if they happen to make carbapenemases, then meropenem and imipenem will no longer be active, and these can potentially overcome those mechanisms of resistance. And in the case of imipenem, because imipenem alone is not stable to AMP-C, if there happens to be an organism such as Pseudomonas that makes AMP-C, then really Bactam can block AMP-C so that imipenem will continue to have activity. So when you compare meropenem, Weber Bactam, and imipenem, really Bactam, the role of imipenem, really Bactam, would be that extra activity against Pseudomonas. Otherwise, they both have good activity against carbapenem resistant Enterobacterialis. And lastly, we have cephalosporin combinations with some beta-lactamase inhibitor. So we have ceftolozane tazobactam. So ceftolozane is kind of similar to cefepime, but it's not available alone. So it was not listed in the previous table. It's only available in combination with tazobactam. So, in general, not much activity for gram-positives, but it has good activity against gram-negatives, particularly for Pseudomonas. So the reason they developed ceftolozane tazobactam was really to target Pseudomonas that were potentially resistant to other available agents. So if you have Pseudomonas resistant to cefepime and, piperacillin tazobactam, or even resistant to carbapenems, if you have Pseudomonas resistant to meropenem, ceftolozane tazobactam could potentially still have activity, so very potent against Pseudomonas. And of course, ceftazidime alone was active against Pseudomonas, and in combination with avibactam, it really has become a potent agent against carbapenem-resistant Enterobacterialis, so CRE. So some of those, E. coli and Klebsiella that make carbapenemases, ceftazidime avibactam could potentially be active against those. So, and ceftazidime avibactam came to the market before we had meropenem-weber-bactam and imipenem-relibactam. So it really had a big role in when we had Enterobacterialis that were resistant to carbapenems. Ceftazidime avibactam would have been the only drug of choice at the time. But nowadays we have these carbapenem combinations with beta-lactamase inhibitors. So we have several options now for carbapenem-resistant Enterobacterialis. Now, daptomycin. Let's talk about the mechanism of action of daptomycin. Its class is cyclic lipopeptide. It binds to bacterial membrane in a calcium-dependent manner, followed by the oligomerization of antibiotic molecules within the cell membrane, which results in depolarization, loss of membrane potential, and cell death. So that's the mechanism of action. And when it comes to resistance, it's more likely to be encountered in enterococci than staphylococci. So, for the most part, MRSA is susceptible to daptomycin. It's really hard to find MRSA that would be non-susceptible to daptomycin. It's more common to find enterococci that might be non-susceptible to daptomycin. Now, something cool about daptomycin is the seesaw effect, which essentially means that as daptomycin MICs go up, in either staphylococci or enterococci, we can see that beta-lactam MIC go down. So it's kind of seesaw. As the MIC of one goes up, the other one goes down. And the mechanism of this effect is not clear, but this has some important roles because if there are situations where we are concerned about resistant development, we could potentially combine beta-lactams and daptomycin, and the combination would be very effective, because if the organisms develops resistant to one, then it becomes more susceptible to the other one, and vice versa. So it's kind of like a seesaw. And this is not just unique to daptomycin, the same effect also applies to vancomycin. So if you were to combine vancomycin with a beta-lactam, there would be a seesaw effect expected, specifically for staphylococci and enterococci. So here's the spectrum of activity of daptomycin. Excellent activity for gram-positives across the board, and absolutely no activity against gram-negative organisms. So this is an antibiotic directed at gram-positives, including MRSA. So excellent activity against MRSA and all sorts of enterococcus, including VRE. So when we have vancomycin-resistant enterococcus, daptomycin would be one of the drugs that would have excellent activity. We described the common mechanisms of bacterial resistance to antibiotics and explained the mechanism of action and spectrum of activity of lipopeptide and beta-lactam antibiotics. Now, given a patient with suspected bacteremia, recommend appropriate empiric therapy. It's important to note that blood is a sterile site. There is no such thing as colonization of blood. Bloodstream infection refers to an infection of the blood. Bacteremia specifically means presence of bacteria in the blood. There is also fungemia, which is presence of fungi in the blood. Candidemia is a specific kind of fungemia, that's specifically Candida species in the blood. And viremia is the presence of viruses in the blood. Bloodstream infection occurs due to translocation of an organism from another body site or seeding of an organism to a foreign object, for example, intravascular catheter or a prosthetic device that communicates with the vascular system. When it comes to bacteremia, it is important to consider infective endocarditis, which is an infection of the cardiac endothelium, and it can present as either acute or subacute disease. Now, infective endocarditis requires imaging such as TTE or TEE. So TTE is transthoracic echocardiography, and TE is transesophageal echocardiography. So these are echoes that can actually look into the heart and see if there is vegetation present. We will not discuss endocarditis in this topic, and I refer you to endocarditis guidelines for further information. Let's take a look at common causes of primary bacteremia. Primary bacteremia is essentially bacteremia that's not secondary to other infections. So for example, people with indwelling catheter can have bacteremia. So bacteria can actually find their way into the bloodstream through the catheter. It can happen through surgery. So people who have had surgery, there could be bacteria introduced into the bloodstream. And of course, people who inject drug can actually introduce bacteria into the bloodstream Now, the common organisms in indwelling catheter bacteremia are coag-negative staph, Staphylococcus aureus, Candida, which is actually a fungus, and Enterobacterales. So mostly things from the skin. So the skin has staphylococci. So either Staphylococcus aureus or coag-negative. Those are the top two, and which also explains surgery. So essentially, because the surgeons will cut the skin open, bacteria from the skin can find their way into the blood. So Staph aureus and coag-negative staph are the top two, and of course E. coli can also happen, depending on the type of surgery. And injection drug use, again from the skin. So Staphylococcus aureus is by far the most common causative organism. Now, for secondary bacteremia, this is essentially bacteremia as a result of another infection. So, for example, a respiratory tract infection such as pneumonia occasionally can lead to bacteremia because the lung has very pretty good perfusion of the blood. So, occasionally in advanced cases of pneumonia, bacteria can find their way into the blood. So, Staphylococcus aureus, Enterobacterales, Pseudomonas, as well as Streptococcus pneumoniae. These are the top organisms that can cause bacteremia in patients with pneumonia. Urinary tract infections, the most common cause of urinary tract infections is E. coli. So in advanced pyelonephritis, for example, which is the infection of the kidneys, because there's a lot of vasculature in the kidneys, in advanced infections, bacteria can find their way into the bloodstream. So E. coli could find its way into the blood. The same is true with enterococci. So enterococcus species can also find their way into the blood from the urine. Now, less common is skin and soft tissue infections leading to bacteremia. So Staphylococcus aureus would be the most common on the skin, as well as coag-negative staph. In general, skin and soft tissue infections are not severe. So typically, unless there is deep tissue wounds and infection, it's pretty rare for bacteria to find their way into the blood from the skin. The same is true with intra-abdominal infections. So in the intra-abdominal infection, we have enteric organisms, so Enterobacterales, as well as anaerobic B. frag, so Bacteroides fragilis. And also enterococci. So enterococci are common in the GI tract. So if there are complications of intra-abdominal infections, these organisms can find their way into the blood. Again, this is pretty rare. Now, when exactly should we suspect bacteremia? So the clinical suspicion of bacteremia could be due to many things. The most common is the SIRS criteria. So the SIRS essentially is the systemic inflammatory response syndrome. There are 4 categories, and in order to meet the SIRS criteria, one patient must have at least 2 of these 4 criteria. So number 1 is the presence of fever, so the temperature of at least 38 degrees Celsius or 100.4 degrees Fahrenheit. That's the definition of fever. Or hypothermia, so if the temperature is actually lower than 36 degrees Celsius or less than 96.8. Now, hypothermia is relatively less common in infections. It's fever that's more common, but again, hypothermia is possible in patients with infections. Second criterion is a heart rate of greater than 90 beats per minute. So this is essentially the body's reaction to blood pressure dropping. So if somebody is having hypotension as a result of systemic reaction to infection, the body will try to compensate. So heart rate greater than 90 is the second one. Third is respiratory rate. So if someone having labored breathing, a respiratory rate greater than 20, or in more advanced, if you have monitoring that can actually measure, partial pressure of CO2. If the CO2 pressure is less than 32, it's a reflection of increased breathing, which essentially depletes the carbon dioxide. And lastly, white blood cell count of greater than 12,000 cells per cubic millimeter, or if there is less than 4,000 cells per cubic millimeter. Alternatively, if there is more than 10% bands, so bands are immature white blood cells. So if more than 10% bands, it's essentially indicating that the body is attempting to make a lot of white blood cells. So white blood cell more than 12,000 is obviously a response to bacterial infections. Alternatively, less than 4,000 is if the body has depleted the white blood cells as a result of dealing with the infection. So occasionally you may see actually a depletion of white blood cells because production cannot keep up with the demand. Now, it is important to note that patients who are receiving glucocorticoids, so let's say prednisone, for example, they can have increased the white blood cell count as a result of it. So that's something to keep in mind when interpreting patients' white blood cells. So if somebody just received glucocorticoid, it is useful to see the white blood cell before they receive glucocorticoid and after to see that this is truly a response to infection and not an artifact of receiving glucocorticoid. So it is important to have at least two of these four. For example, a fever alone is not an indication of infection, but if you have, for example, fever and white blood cell elevation, that's more likely to be an infection. And we'll talk about different things that can lead to fever because there are non-infectious causes of fever. The same with heart rate and respiratory. So if you have at least two of these, it's more likely to be an infection, and bacteremia will be top of the list. And next we have suspected sepsis. We will discuss sepsis on another day in the course, so I'm not going to go into discussion of sepsis, but typically when there is sepsis suspected, bacteremia is on differential diagnosis. If the patient has hypotension or shock, if the blood pressure is dropping, if patient requires fluid resuscitation and perhaps vasopressors in order to bring the blood pressure back to normal, should suspect bacteremia. Of course, if there is already indwelling catheter, you suspect that bacteria have been entering the bloodstream. And of course, some non-specific factors. So for example, if there are inflammatory markers that are elevated, so such as C-reactive protein or ESR or procalcitonin, for example, that's an indication that there could potentially be bacteremia in the patient. Now, when counting number of positive bottles of blood when we send them to the lab for blood cultures, it is important to know how blood cultures are obtained. In general, blood culture consists of a set of 2 bottles. So if each set have 2 bottles, and in each bottle there's 10 ml of blood. And of the 2 bottles in one set, one is for aerobic and one for anaerobic. So the way they grow them in the lab, they require different conditions. So one bottle is used for aerobic conditions to see if there is any aerobic bacteria growing, and another one is used for anaerobic. Now, because it is possible to contaminate these bottles, so technicians use proper techniques to collect these bottles, but the techniques are not perfect, so occasionally they could get contaminated. So it's important to have more than one set of bottles in case there is contamination. Then you have a second set to verify it. So you end up with 4 bottles, when you get 2 sets. So when describing positivity, the number of bottles positive will be described. So for example, you might hear that a patient had 1 of 4 bottles positive for Coag-negative staph. So that's what they're referring to when they talk about the bottles. Now, let's look at some possible origins of a fever. So of course, in this course, we are interested in infections as a cause of fever. But also keep in mind that other things can lead to fever, such as malignancies. So different types of cancer can lead to fever. Some autoimmune conditions can lead to fever. Even a DVT, deep vein thrombosis. Not in every patient, but occasionally some patients with the DVT can develop a fever because of that. And there's even drug-induced fever. So many drugs can occasionally cause fever, not in every patient, but occasionally they can. And when they do cause a fever, this typically happens after 7 to 10 days, when the first time the patient is exposed to these drugs. Now, if you discontinue the drug, it pretty much, the fever disappears pretty rapidly when you discontinue. And when you re-challenge the patient, it actually the fever develops within a few hours. So that's pretty much the only way to verify if this is a drug-induced fever. So if one, and the most common drugs are listed in this table. For the sake of this course, beta-lactams can cause drug fever. Minocycline can, if you don't have other reasons for a fever and you suspect one of these drugs, you essentially discontinue it. The fever should rapidly go away, and then you restart it. And if the fever comes back, you essentially conclude that this is a drug-induced fever. And of course, the worst case scenario, if you don't have an origin for the fever, is actually referred to as fever of unknown origin. Which going back to the SIRS criteria, it's important that if you only have fever and you cannot identify what's causing the fever, a fever alone is not indication of infection. You really should rely on the SIRS criteria, so you should find a second criteria to conclude that it's an infection. Now, let's discuss contamination of blood samples. So because blood cultures are commonly contaminated with skin flora, specific organisms may be contaminants. And the most likely contaminants are Coag-negative staph, Bacillus species, Micrococcus, Corynebacterium, Cutibacterium. So these are the ones that are more likely to be a contaminant. So what it means is that if you have 1 out of 4 bottles growing Coag-negative staph, you essentially conclude that it's a contaminant. But if you have 2 out of 4 growing Coag-negative staph, because you have 2 of the bottle growing, that's unlikely to be a contaminant. So you conclude that it's a true infection due to Coag-negative staph. Now, you only do that with these organisms. There are these other organisms that you never consider a contaminant. So Staphylococcus aureus, for example, because it's a deadly bacterium, if you only have 1 out of 4 bottles growing Staphylococcus aureus, you are obligated to treat it. You cannot count it as a contaminant, because if you happen to be wrong about the contaminant, Staphylococcus aureus can kill the patient pretty quickly. The same with the rest of these organisms here. So Streptococcus pneumoniae, group A streptococci, any of the gram-negative bacteria, Bacteroides, and even the fungus Candida species. If you have even 1 out of 4 bottles growing any of these, you should consider it bacteremia and treat it. Now, viridans, strep, and enterococci, these are tricky. So they may be true pathogen or they may be contaminant. It's really they are considered on a case-by-case basis, and typically infectious diseases physicians will be consulted for these to decide if it's a true infection or a contaminant. Now, let's talk about management of bacteremia. So blood cultures before antibiotics are essential, if possible. So if even 1 dose of antibiotic can actually eradicate organisms from the blood sample, so it can actually reduce the yield. So it will be more likely that nothing will grow out of the blood culture. So it's important to get the blood cultures before initiating antibiotics. But I say if possible, because, for example, if it's taking too long for the, if the staff are not available to get the blood cultures, which is extremely rare, you don't want to delay antibiotics. So it has to be within reason. In general, you want to give antibiotics within 1 hour. But if it's taking like 2 or 3 hours for someone to come and get the blood cultures, it's okay to give the antibiotics before blood cultures, because we don't want that to be at the cost of harming the patient. Now, source identification. It's important to know how the bacteria got into the blood, right? So bacteria don't belong to the blood, so you need to identify the source. And that's important because we're going to talk about source control. Because without source control, you can continue to give antibiotics. Once you stop antibiotics, if you haven't removed the source, the bacteria will continue to come back. So it's extremely important to identify the source. So catheter-related bloodstream infections, which essentially would lead that to the fact that the catheter will have to be removed and replaced with a new one. You can so if there is a catheter in place, you suspect that is the source of the bacteremia, and the catheter tip, for example, can be cultured to see it grows something that matches the blood culture. Symptoms, you can use the symptoms to identify where in the body the bacteria are coming from. So for example, if there is pain, for example, if there is low back pain, you might consider that there might be kidney infection. So you can use the site of pain to identify where the infection is coming from. Or if there is inflammation in a certain location, perhaps maybe it's a joint, or anything that you can identify from the symptoms. Microbiological cultures of the site. So if there is a wound, for example, and you culture it and you grow something, and the same thing is growing in the blood, or if you have a respiratory culture and it's growing something that matches what's growing in the blood, that identifies the source of the bacteremia. And of course, sometimes you just cannot easily find the source, so you may need something like imaging to kind of show you, within the body if there are, processes that could be due to infection. And of course, you identify the source in order to have source control. So you remove the source if possible. For example, if there are extravascular devices such as central line or prosthetic joint, you essentially remove them if possible. And once the infection is treated, you can replace these. And sometimes they may require consultation of other specialties. For example, if someone has cardiac hardware, cardiology team may be needed in order to assess whether its removal is possible. And sometimes surgery is needed, so surgical debridement. So if surgically they need to go in there and remove dead tissue, any things like biofilm, which we'll talk about another day. But surgical debridement can also be helpful for source control. Now, for the empiric treatment of bacteremia, it is important to start treatment early in order to decrease the rate of mortality. And the choices of antibiotics really depend on the source, if known, and also on the history of the patient. So for example, if the patient has a history of multi-drug resistant organism, then broader antibiotics are needed empirically. And of course, tools such as gram stain as well as rapid diagnostic tests are available to optimize the empiric therapy as soon as possible. Now, initially, empiric treatment should be intravenous because the infection is in the blood, and IV antibiotics give the antibiotic 100% into the site of infection. Now, there are some antibiotics that do not achieve enough concentration in the blood and should be avoided, regardless of whether oral or IV. So nitrofurantoin does not achieve enough concentration. It goes straight into the urine. Colistin, which is an IV antibiotic, does not achieve enough concentration in the blood, goes straight into the urine, as well as tetracyclines. So tetracyclines, especially tigecycline, have very large volume of distribution. So they basically achieve high concentrations in most tissue in the body, but very little stays in the blood. So they are not ideal for bacteremia. In fact, there is a black box warning for tigecycline for increased risk of mortality as a result. And rapid diagnostic tests such as multiplex PCR are able to identify or select organisms as well as resistance early on. So within 24 hours of infection, these results can be available, which are often used in the sense that if one of these genes show up, then if the empiric treatment is not covering that specific resistant organism, then the treatment can be escalated. We described the common mechanisms of bacterial resistance and explained the mechanism of action of beta-lactams. Given a patient case, we recommended effective drug therapy for the treatment of bacteremia. Now, let's change empiric therapy to pathogen-directed therapy based on blood culture and susceptibility results. When susceptibility results become available, therapy must be changed to a more narrow spectrum agent based on those results. Now, occasionally escalation is needed if the organism is resistant to what we were using as empiric therapy. Now, while initially IV antibiotics are required for treatment of bacteremia, oral antibiotics can be considered, especially those with good bioavailability more than 90%, and preferably the ones that have clinical data to support use. Most clinical experience with oral antibiotics is for gram-negative bacteremias. With gram-positive bacteria, because of a more serious complications such as endocarditis and difficulty to eradicate due to formation of biofilm of gram-positive organisms, especially with Staphylococcus and Enterococcus species, IV antibiotics have historically been recommended for the entire duration of therapy. However, recent clinical trials such as the POET trial that included patients with endocarditis suggest that oral antibiotics may be used for gram-positive bacteremia as well. Let's take a look at available options for definitive treatment of MSSA bacteremia. So we have a lot of antibiotics that have in vitro activity against MSSA, for example, vancomycin, nafcillin or oxacillin, which are anti-staphylococcal penicillins. So these are similar to methicillin. Cefazolin, which is a first-generation cephalosporin. Ceftriaxone, which is a third-generation cephalosporin. And piperacillin tazobactam, which is also in the penicillin class. Now, the standard of care for treatment of MSSA bacteremia is to start with IV antibiotics. So all of these agents are available as IV only. And when you compare these, you will see that vancomycin is associated with nephrotoxicity. So is nafcillin and oxacillin. Nafcillin's more than oxacillin, but regardless, both of them are associated with nephrotoxicity, whereas cefazolin is not associated with nephrotoxicity, neither is ceftriaxone. Piperacillin tazobactam has also been associated in observational studies with nephrotoxicity. Now, with hepatotoxicity, specifically elevation of transaminases such as ALT and AST, you will see that nafcillin or oxacillin significantly increase transaminases, whereas the rest of these do not significantly increase transaminases. And when it comes to cost, most of these are pretty affordable with the exception of nafcillin or oxacillin. So these are pretty expensive in the range of hundreds of dollars per dose. So between $100 to $200 per day. Now, what we have seen in observational studies And this is because we do not have head-to-head randomized control trials to compare these. So what we have is observational studies is that nafcillin or oxacillin are actually superior to vancomycin in regards to clinical outcomes. So vancomycin is actually inferior to these as well as cefazolin, whereas cefazolin, nafcillin, or oxacillin have similar efficacy. And of course, you will see that the advantage goes to cefazolin because it is better tolerated, so it's less likely to cause nephrotoxicity and hepatotoxicity, and it's more affordable. And also the dosing is more convenient. So this is 2 grams IV every 8 hours, so only 3 times a day, whereas nafcillin and oxacillin need to be given every 4 hours, or you can do the entire 12 grams as a continuous infusion. So, pretty much around the clock. So that's inconvenient. Now, historically, nafcillin or oxacillin have been considered the standard of care for MSSA bacteremia. However, in recent times, cefazolin has become a better option. So, cefazolin, pretty much everything that you look at has a better profile compared to nafcillin and oxacillin. Now, there are other beta-lactams that also have activity against MSSA bacteremia. For example, ceftriaxone and piperacillin tazobactam. And a lot of patients may be on these agents empirically, but when the culture results come back and it is MSSA, it is important to switch the patients to either cefazolin or nafcillin or oxacillin, because again, based on observational studies, both ceftriaxone and piperacillin tazobactam had inferior effectiveness compared to cefazolin or nafcillin or oxacillin. Now, when it comes to oral options, so after a few days of IV, it may be appropriate to transition patients to oral in case they need to be discharged from the hospital. However, current evidence does not support oral step down as a routine practice for MSSA bacteremia specifically, and that's based on observational studies. Now, recently the Sabato randomized control trial actually evaluating oral options such as trimsulfa or clindamycin after 5 to 7 days of IV antibiotics for uncomplicated MSSA bacteremia. This trial has been concluded, but the results are not published yet, and it is likely that they will show oral option after 5 to 7 days of IV antibiotics to be non-inferior to a full 14 days of IV antibiotics. Now let's take a look at pathogen-directed therapy for bacteremia. First, let's consider methicillin susceptible Staphylococcus aureus or MSSA. So for MSSA, treatment of choice is either an anti-staphylococcal penicillin such as nafcillin or oxacillin or cefazolin, and these are considered first choice. They are all superior to vancomycin for definitive treatment of MSSA bacteremia because they have mortality benefit. So if patients receive vancomycin for pathogen-directed MSSA bacteremia, they're more likely to die compared to receiving these. Now, cefazolin is first-generation cephalosporin, and compared to nafcillin and oxacillin, cefazolin is a much safer option. So both nafcillin and oxacillin are nephrotoxic. So, patients are more likely to develop nephrotoxicity compared to receiving cefazolin. In addition, nafcillin and oxacillin are more likely to be hepatotoxic, so they are more likely to result in increased AST and ALT, so transaminases. And when you look at the dosing, I haven't listed the dosing for these agents here. Cefazolin is dosed every 8 hours, whereas nafcillin and oxacillin are actually dosed more frequently, every 4 hours. So it makes it more difficult to administer. Cefazolin, much better option. Now, of course, if somebody cannot tolerate beta-lactams, then vancomycin would be an alternative option for them. For MRSA bacteremia, drug of choice is vancomycin or daptomycin. Vancomycin is historically more affordable than daptomycin, so people most often use vancomycin. Now that is based on directed cost of acquisition when you compare vancomycin to daptomycin. Now, if you consider that vancomycin requires therapeutic drug monitoring, so you essentially need to pay a pharmacist to basically get vancomycin levels and make adjustment. One could argue that daptomycin might be more cost effective. But regardless, either vancomycin or daptomycin would be treatment of choice for MRSA. And the reason linezolid is not considered drug of choice is because typically with MRSA, we need to treat for at least 2 weeks. And linezolid becomes problematic when you treat for long periods because of adverse effects. So vancomycin and daptomycin are much better tolerated, and they're considered drugs of choice. Now, however, everything we have listed so far is only available as IV. One advantage of linezolid is that it is available as PO. So it would make it easier when transitioning from IV to PO. Now, in general, with MRSA, for the most part, we treat the entire duration as IV. In the POET trial, no patient had MRSA. So although, there is some evidence for oral treatment of gram-positive bacteremia, none of those patients had MRSA. So, pretty much standard of care right now for MRSA, for the most part, is IV treatment. Now, for VRE, which is vancomycin-resistant enterococcus, vancomycin, of course, is no longer an option because this is resistant to it. So now you have daptomycin or linezolid. And, with VRE, you don't need to treat as, for very long times as we do for MRSA. So typically shorter duration of treatment. So, linezolid becomes an option. And when you compare daptomycin to linezolid, daptomycin might have an advantage because, for one, linezolid is bacteriostatic, but daptomycin is bactericidal, so has more potent activity. But also, daptomycin is easier because it's in normal renal function, it's administered once a day, whereas linezolid is typically twice a day. But on the other hand, again, linezolid has an oral option, whereas daptomycin doesn't. So, there are pros and cons, but regardless, both of them are considered treatment of choice for VRE bacteremia. And so these were gram-positives. When it comes to gram-negatives, one thing that's very important is treatment of ESBL bacteremia. And carbapenems are considered first-line treatment for ESBL bacteremia. In fact, meropenem was shown to be superior to piperacillin tazobactam in randomized controlled trial. So people were less likely to die if they were receiving meropenem compared to piperacillin tazobactam. So there's mortality benefit with carbapenem. So now they are considered first line for ESBL bacteremia. And cefepime should be avoided because of increased risk of mortality. And this is, regardless of susceptibility. So if the patient has blood cultures growing, let's say ESBL producing E. coli, and is susceptible to piptazo and cefepime as well as meropenem, we should avoid using cefepime even though it is susceptible, and we should avoid using piperacillin tazobactam, and we should use a carbapenem because of the mortality benefit. And lastly, other gram-negative organisms, considering they are not multi-drug resistant, because there are other resistant scenarios that are beyond the scope of this lecture. So we will not cover carbapenem-resistant Enterobacterialis. I will refer you to IDSA guidelines for treatment of those infections. Multi-drug resistant Pseudomonas, Cinetobacter, and other multi-drug resistant organisms we will not cover in this lecture. So other gram-negative organisms that are pretty much easy to treat, things like a normal E. coli that's not resistant to multiple drugs, or even Pseudomonas that's not resistant to multiple drugs. So essentially wild-type gram-negative organisms. You essentially choose the narrowest agents based on susceptibility results and PK/PD properties, meaning you want to choose agents that have good concentrations in the blood. For example, you want to avoid tetracyclines in general, because tetracyclines have a high volume of distribution, meaning that they distribute throughout tissue, so very little concentration remains in the blood. So if your treatment, if the site of infection is in the blood, you actually want the drug to stay in the blood and not go to other tissues. And things like doxycycline, tigecycline, these are antibiotics that do not achieve high concentrations in the blood and should be avoided. Now, for oral treatment of gram-negative bacteremia, there are certainly more data when it comes to oral IV to PO switch for gram-negatives. And in general, we want to use high bioavailability drugs such as fluoroquinolones and trimsulfa. So you can see trimsulfa and fluoroquinolones have high bioavailability. Now that's preferred, occasionally, if the patient cannot get these, then and only then oral beta-lactams may be considered, but you do have to make sure that you give a high dose to make sure you get enough concentration in the blood. So these are pretty high dose. If you are to use amoxicillin, you want 1 gram every 8 hours, or if amoxicillin clavulanate, it's at least 875 milligram, ideally 1 gram PO every 8 hours. If it's cephalexin, 1 gram PO every 6 hours. Now these three are preferred if you are to use an oral beta-lactam, and there are less data for the other oral. So if it's best to avoid the other ones due to lack of enough studies showing that you could get enough concentration with cefdenier, cefodoxime, and cefadroxil. But if you cannot achieve, if the patient cannot get these other, you could potentially use this, but you have to make sure that you use higher doses than normally we use. So you want to optimize the dose. We described the common mechanisms of bacterial resistance and mechanism of action of beta-lactams. We recommended effective drug therapy for the treatment of bacteremia, and we changed empiric therapy to pathogen-directed therapy based on blood culture and susceptibility results. Now, let's select total duration of therapy for bacteremia based on causative organism. Here are some general principles for management of bacteremia. So it is important to repeat blood cultures every 1 to 2 days, so every 24 to 48 hours after a positive blood cultures until there is a negative culture. And in general, the very first blood culture that's available, that would be considered day 1 of therapy. And that is because that's when we confirm that the source of infection has been controlled. Because for many of these bacteremia where the source of infection is not controlled, blood cultures continue to be positive for many days. So as long as the source of infection is not controlled, any antibiotics that has been used has not really been able to eradicate the infection. Now, for uncomplicated gram-negative bacteremia, a total of 7 days is appropriate. Specifically in patients who have achieved source control, are afebrile for at least 48 hours, and are hemodynamically stable. Especially if the source of bacteremia is from the urine caused by Enterobacteriaceae. Otherwise, a longer duration of therapy of 14 days may be needed based on clinical judgment, especially for non-fermenting gram-negative organisms such as Pseudomonas and Acinetobacter. Now, it's important to note that there are no clinical practice guidelines for gram-negative bacteremia. So you may see that at different places, practice might be different. For MRSA specifically, there is an IDSA guideline that was published in 2011. And it recommends that for adults with uncomplicated MRSA, vancomycin or daptomycin for at least 2 weeks is recommended. And the definition of uncomplicated MRSA bacteremia is someone who does not have endocarditis. There are no implanted prostheses, so no hardware. Follow-up blood culture performed on specimen obtained 2 to 4 days after the initial set that do not grow MRSA, so there should be a negative culture within 2 to 4 days. And defervescence within 72 hours of initiating effective therapy. And defervescence basically means resolution of fever within 72 hours. And there should be no evidence of metastatic site of infection. In other words, the infection should not be going from the blood to other organs or any other site. If the patient meets all of these criteria, the bacteremia will be considered uncomplicated. Otherwise, if the answer to any of these is yes, then the patient has complicated MRSA bacteremia, and then the duration of treatment is 4 to 6 weeks, so at least 4 weeks. And then the way, whether it should be 4 weeks, 5 weeks, or 6 weeks depends on how the patient responds during the first 4 weeks and based on the clinical judgment of the clinicians. This concludes this presentation.